Meningitis Epidemiology in Neonates reveals the statistical patterns and population-based risk factors that help clinicians understand who faces greatest danger from this devastating central nervous system infection. The overall incidence of less than 1 per 1,000 live births provides baseline population risk, but this average masks dramatic variation across different groups. Think of this like understanding crime statistics for an entire city. The overall number seems manageable until you examine specific neighborhoods where rates prove much higher. The relationship between bacteremia and meningitis shows that 15 to 38% of neonates with positive blood cultures also develop central nervous system infection. This high conversion rate distinguishes neonatal populations from older children, where meningitis accompanies bacteremia much less frequently. This pattern reflects age-specific vulnerabilities rather than pathophysiologic mechanisms. A particularly concerning finding shows that 25% of very low birth weight infants with meningitis have negative blood cultures. This epidemiologic observation creates diagnostic challenges because traditional screening approaches may miss significant numbers of central nervous system infections in the most vulnerable population. Risk factor analysis reveals prematurity as the strongest predictor, with rates increasing dramatically as gestational age decreases. Very low birth weight compounds this risk through mechanisms beyond simple prematurity. Maternal factors including prolonged rupture of membranes exceeding 18 hours and chorioamnionitis create early onset disease patterns. Environmental risks continue throughout hospitalization, with invasive procedures like lumbar punctures, central line placements, and surgical interventions creating ongoing exposure opportunities. The cumulative effect of these factors explains why certain NICU populations face meningitis rates far exceeding general newborn averages. Understanding these epidemiologic patterns allows clinicians to stratify risk appropriately and maintain heightened vigilance in high-risk populations where early detection proves crucial for preventing devastating long-term neurological consequences. Meningitis pathophysiology explains the biological mechanisms through which bacterial infections establish within the central nervous system and create the tissue damage that leads to neurological injury. Blood-brain barrier immaturity serves as the fundamental vulnerability that makes neonatal meningitis possible. This specialized barrier consists of tightly joined endothelial cells that normally prevent harmful substances from crossing from blood into brain tissue. In neonates, incomplete development creates gaps that allow enhanced bacterial penetration while also permitting increased inflammatory molecule passage that amplifies tissue damage. Bacterial invasion follows 3 distinct pathways. Hematogenous spread represents the most common mechanism, where circulating bacteria in bloodstream infections encounter and cross the immature blood-brain barrier to establish cerebrospinal fluid infection. Direct extension occurs when bacteria from adjacent infected structures like sinuses or middle ears penetrate through anatomical connections to reach the central nervous system. Neural tube defects provide direct communication between external environment and cerebrospinal fluid, creating unprotected pathways for bacterial entry. Once bacteria establish central nervous system presence, the inflammatory cascade begins with immune system recognition, triggering release of powerful inflammatory mediators. These substances, designed to eliminate invading organisms, create collateral damage within the confined skull space where tissue expansion cannot occur. Brain edema develops as inflammatory mediators increase blood vessel permeability, allowing fluid to leak into brain tissue. The rigid skull prevents outward expansion, creating dangerous intracranial pressure increases that compress vital neural structures and impair normal brain function. Vasculitis represents the most destructive consequence, where inflammation directly damages blood vessel walls throughout the brain. This vascular injury disrupts normal blood supply through thrombosis formation and vessel wall breakdown, leading to tissue infarction and permanent brain damage in affected regions. The confined space amplifies all these processes, making brain inflammation particularly destructive compared to infections in other body regions where swelling can expand harmlessly outward. Meningitis clinical presentation in the early stages creates one of the most challenging diagnostic scenarios because symptoms often appear deceptively mild and nonspecific. Understanding these early manifestations requires recognizing that the neonatal nervous system expresses distress through subtle changes rather than the dramatic signs seen in older patients. Temperature instability emerges as the most common early finding, but the pattern differs significantly from typical expectations. Hypothermia occurs much more frequently than fever, particularly in preterm infants whose immature thermoregulatory systems cannot mount appropriate febrile responses. When fever does occur, it may be intermittent or low grade, making temperature patterns unreliable for excluding serious infection. Feeding difficulties provide crucial early clues because the neurologic centers controlling feeding behavior become disrupted before more obvious signs develop. Poor sucking strength reflects impaired cranial nerve function, while feeding refusal may indicate nausea or general malaise that infants cannot verbally communicate. Vomiting and abdominal distension can result from increased intracranial pressure affecting the autonomic nervous system, creating gastrointestinal symptoms that might mislead clinicians toward abdominal pathology. Behavioral changes offer some of the most sensitive early indicators, though they require careful observation to detect. Lethargy manifests as decreased spontaneous movement, reduced interaction with caregivers, or prolonged sleep periods. Paradoxically, irritability can also signal central nervous system irritation, creating a restless, inconsolable state where normal comfort measures prove ineffective. The development of a high-pitched cry represents neurologic irritation from inflammation affecting pain pathways or increased intracranial pressure. This distinctive cry quality differs from normal infant crying and often persists despite attempts at consolation. Decreased activity encompasses reduced muscle tone, diminished reflexes, and overall listlessness that caregivers often describe as the baby not acting like themselves. Respiratory symptoms, including distress and apnea, can result from direct brainstem involvement or from increased intracranial pressure affecting respiratory control centers. These manifestations may appear identical to primary lung disease, potentially delaying recognition of the underlying central nervous system infection. The critical clinical principle involves understanding that early meningitis can mimic sepsis alone, making lumbar puncture essential when central nervous system infection remains a possibility. This overlap occurs because both conditions share common pathophysiologic pathways, and because meningitis often accompanies systemic bacterial infection. Neurologic signs in neonatal meningitis represent the progression from early subtle changes to more obvious manifestations of central nervous system dysfunction. These findings indicate that inflammation has progressed sufficiently to impair specific neurologic functions, making recognition crucial for appropriate treatment intensity. Altered consciousness presents as a spectrum from mild lethargy to profound unresponsiveness. Unlike older children who can verbally report confusion or headache, neonates demonstrate consciousness changes through behavioral modifications. Difficulty arousing the infant for feeds or routine care suggests depressed mental status, while poor visual tracking indicates impaired cortical function affecting visual processing pathways. Tone abnormalities follow a predictable temporal pattern that reflects the progression of central nervous system inflammation. Early hypotonia, or floppy baby syndrome, occurs as generalized brain dysfunction reduces normal muscle tension. This presents as decreased resistance to passive movement, reduced spontaneous motor activity, and poor head control even for gestational age expectations. As inflammation progresses and intracranial pressure increases, hypertonia develops with characteristic positioning abnormalities. Opisthotonus, where the neck and back arch backward in extreme extension, represents severe brainstem irritation and indicates advanced disease requiring immediate intervention. This progression from hypotonia to hypertonia serves as a clinical marker of worsening neurologic status. Seizure activity occurs in 25 to 40% of neonatal meningitis cases, with patterns varying by both pathogen and gestational age. Gram-negative bacteria, particularly E. coli, more commonly cause focal seizures because these organisms demonstrate enhanced ability to create localized brain abscesses and tissue destruction. The focal nature reflects specific brain regions affected by vascular compromise or direct bacterial invasion. Preterm infants present unique challenges because their seizures often appear subtle rather than displaying obvious convulsive movements. These subtle seizures may manifest as eye deviations, lip smacking, cycling movements, or apneic episodes that can be easily overlooked without careful observation and monitoring. Bulging fontanelle represents a late finding indicating significantly elevated intracranial pressure. The anterior fontanelle normally feels soft and slightly concave, but with increased pressure becomes tense and protrudes above the level of surrounding skull bones. This finding suggests advanced disease where immediate pressure reduction becomes necessary. Cranial nerve palsies can develop when inflammation or increased pressure affects specific nerve pathways. These may present as facial asymmetry, poor pupillary responses, or feeding difficulties from impaired cranial nerves, controlling swallowing and sucking reflexes. Cerebrospinal fluid analysis represents one of the most challenging diagnostic procedures in neonatal medicine because normal values change dramatically with gestational and postnatal age, creating moving targets that can confuse even experienced clinicians. Understanding these age-related variations becomes essential for distinguishing normal findings from pathologic changes that might indicate serious infection. Think of cerebrospinal fluid analysis like interpreting a foreign language where the vocabulary changes depending on the speaker's age. What represents normal communication in one age group might signal alarm in another. This analogy helps explain why neonatal CSF interpretation requires such careful attention to developmental context rather than applying adult reference ranges that would be completely misleading. Term infants during their first 30 days of life demonstrate CSF patterns that reflect the transition from intrauterine to extrauterine life. The white blood cell count can reach up to 30 cells per microliter without indicating infection, with lymphocytes comprising approximately 60% of these cells. This lymphocytic predominance reflects the normal immune surveillance that occurs within the central nervous system, where specialized cells patrol for potential threats while maintaining the sterile environment essential for proper brain function. Protein concentrations in term infants range from 20 to 150 milligrams per deciliter, values that would seem alarmingly elevated in older children or adults. This elevation occurs because the blood-brain barrier continues maturing during the early postnatal period, allowing more protein molecules to cross from blood into cerebrospinal fluid than would normally occur in fully developed systems. Think of this like a construction site where the permanent barriers have not yet been completed, allowing temporary passage of materials that will later be excluded. Glucose ratios provide perhaps the most reliable indicator of normal versus abnormal cerebrospinal fluid. The CSF glucose should exceed 50% of simultaneously measured serum glucose or maintain absolute values above 40 milligrams per deciliter. This ratio reflects active transport mechanisms that move glucose from blood into cerebrospinal fluid to fuel the brain's enormous metabolic demands. Preterm infants present even more complex interpretation challenges because their values exceed term infant ranges while remaining within normal limits for their developmental stage. White blood cell counts can reach 50 cells per microliter, nearly double the term infant limit, while protein concentrations can reach 200 milligrams per deciliter. Most importantly, protein levels demonstrate inverse relationship with gestational age. The more premature the infant, the higher the normal protein concentration. Understanding traumatic tap correction becomes crucial because lumbar punctures in neonates frequently encounter small amounts of blood that can artificially elevate white blood cell counts. The correction formula suggests subtracting 1 white blood cell for every 500 to 1,000 red blood cells present, though this calculation provides only rough estimates and should never replace clinical judgment when interpreting potentially infected cerebrospinal fluid. Cerebrospinal fluid findings in bacterial meningitis create dramatic departures from normal values that reflect the intense inflammatory battle occurring within the central nervous system. Understanding these abnormalities helps explain both the diagnostic utility of lumbar puncture and the pathophysiologic processes that lead to brain damage during untreated infection. White blood cell elevation to levels exceeding 1,000 cells per microliter represents the massive immune system mobilization responding to bacterial invasion. This dramatic increase, often 10 to 50 times normal values, reflects neutrophil recruitment from bloodstream into cerebrospinal fluid as the body attempts to contain and eliminate bacterial invaders. Think of this like watching a peaceful neighborhood suddenly flood with emergency responders when a serious threat emerges. Neutrophil predominance exceeding 80% distinguishes bacterial from viral infections, where lymphocytes typically predominate. This cellular pattern reflects the acute inflammatory response, where neutrophils serve as first responders designed for rapid bacterial killing. The overwhelming neutrophil presence indicates that the immune system has recognized a bacterial threat, requiring immediate, aggressive action rather than the more measured response seen with viral infections. However, the concerning reality involves the 5 to 10% of bacterial meningitis cases that present with normal or only mildly elevated white blood cell counts. This pattern typically occurs very early in infection, before significant immune cell recruitment has occurred, or in overwhelming infections where the immune system becomes suppressed. These cases present diagnostic nightmares because traditional screening approaches may provide false reassurance while serious infection progresses untreated. Protein elevation above 150 to 200 milligrams per deciliter reflects multiple pathophysiologic processes occurring simultaneously. Bacterial toxins and inflammatory mediators increase blood-brain barrier permeability, allowing plasma proteins to leak into cerebrospinal fluid. Additionally, tissue breakdown from inflammatory damage releases intracellular proteins into the CSF compartment. When ventriculitis develops, protein levels can reach extremely high values as inflammation directly affects brain tissue adjacent to the ventricular system. Glucose depression below 50% of serum values, or absolute levels under 20 milligrams per deciliter, occurs through several mechanisms that highlight the metabolic chaos created by bacterial infection. Bacteria consume glucose for their own metabolism, while inflammatory cells also dramatically increase glucose utilization. Simultaneously, inflamed tissues demonstrate impaired glucose transport from blood into cerebrospinal fluid, creating a supply-demand mismatch that rapidly depletes CSF glucose stores. When glucose levels fall below 20 milligrams per deciliter, this indicates particularly poor prognosis because such severe depletion suggests either overwhelming bacterial burden or advanced inflammatory damage that has severely impaired normal metabolic processes. Gram stain positivity in 60 to 80% of cases provides immediate diagnostic information that can guide therapy hours before culture results become available. The variability in detection rates depends on bacterial concentration, previous antibiotic exposure, and technical factors during specimen processing. Culture results remain the diagnostic gold standard because they provide both definitive organism identification and antimicrobial susceptibility testing, essential for optimal therapy. However, the time required for bacterial growth means that treatment decisions must often proceed based on clinical presentation and preliminary laboratory findings, rather than waiting for definitive microbiologic confirmation. Group B streptococcus stands as the most common cause of neonatal meningitis, accounting for 38 to 45% of all central nervous system infections. Understanding why this organism demonstrates such neurotropism helps explain both its clinical patterns and the devastating consequences that can follow infection. The remarkable specificity of serotype 3 for meningitis, representing 80% of GBS central nervous system infections, reveals fascinating bacterial biology. While multiple GBS serotypes can cause bloodstream infections, serotype 3 possesses unique surface characteristics that enhance its ability to cross the blood-brain barrier and survive within cerebrospinal fluid. Think of this like having a master key that opens locks other keys cannot. Serotype 3's polysaccharide capsule provides specialized access to the central nervous system that other strains lack. The temporal patterns of GBS meningitis create important clinical distinctions. Early onset disease follows the vertical transmission pathway we've discussed, where maternal colonization leads to ascending infection or acquisition during delivery. However, late onset GBS disease demonstrates even higher rates of meningitis development, often exceeding 50% of infected infants. This increased neurotropism in late onset disease occurs because the organisms have more time to establish bloodstream infection and find their way across the maturing but still vulnerable blood-brain barrier. CSF findings in GBS meningitis follow the classic bacterial pattern with some distinctive features. White blood cell counts typically exceed 1,000 with neutrophil predominance, while protein elevations can reach extremely high levels, sometimes exceeding 400 milligrams per deciliter. The glucose depression usually remains moderate compared to gram-negative infections, though still falling below the critical 50% ratio of serum values. Despite the serious nature of GBS meningitis, outcomes generally prove better than those seen with gram-negative organisms. This improved prognosis likely reflects both the organism's lower tendency to cause tissue destruction and its consistent sensitivity to penicillin-based antibiotics. Recovery rates and neurologic outcomes, while still concerning, typically exceed those seen with E. coli or other gram-negative meningitis pathogens. The clinical pearl involves understanding that GBS meningitis, while serious, represents a potentially treatable condition when recognized early and managed aggressively with appropriate antimicrobials. E. coli emerges as the most devastating neonatal meningitis pathogen, representing 30 to 40% of gram-negative central nervous system infections while carrying mortality rates that can reach 20 to 60%. Understanding why this organism creates such destruction helps explain the urgency required for recognition and treatment. The K1 capsular antigen appears in approximately 80% of E. coli strains, causing meningitis, representing a critical virulence factor that explains this organism's particular neurotropism. The K1 polysaccharide capsule chemically mimics components of human neural cell adhesion molecules, essentially allowing the bacteria to disguise themselves as belonging in the brain environment. This molecular mimicry enables enhanced penetration across the blood-brain barrier and resistance to normal immune clearance mechanisms once infection establishes. The mortality statistics reflect E. coli's enhanced virulence compared to gram-positive organisms. Unlike GBS, which typically causes inflammation without extensive tissue destruction, E. coli produces toxins and enzymes that directly damage brain tissue. The wide mortality range from 20 to 60% correlates with factors including gestational age at infection, time to treatment initiation, and the presence of complications like ventriculitis or abscess formation. E. coli's association with severe ventriculitis creates particularly challenging clinical scenarios. When infection spreads into the ventricular system, inflammatory debris can obstruct cerebrospinal fluid flow pathways, leading to hydrocephalus that may require neurosurgical intervention. The proximity of infection to vital brain structures in the periventricular region increases the risk of permanent neurologic damage. Brain abscess formation represents another devastating complication that occurs more frequently with E. coli than other neonatal pathogens. These localized collections of infected tissue create space-occupying lesions that can cause herniation while serving as protected reservoirs that resist antibiotic penetration. Management often requires neurosurgical drainage in addition to prolonged antimicrobial therapy. The development of hydrocephalus, whether from ventriculitis or inflammatory adhesions blocking CSF flow, often necessitates placement of ventricular shunts. These devices create ongoing infection risks while requiring multiple surgical procedures throughout the child's life. Poor CSF sterilization distinguishes E. coli from gram-positive pathogens, often requiring prolonged antibiotic courses and repeat lumbar punctures to document clearance. This persistence likely reflects biofilm formation and the organism's ability to survive within brain tissue compartments where antibiotic penetration remains suboptimal. The worst neurodevelopmental outcomes associated with E. coli meningitis reflect both the direct tissue destruction and the complications that frequently accompany infection. Survivors often face cerebral palsy, intellectual disabilities, seizure disorders, and sensory impairments that require lifelong supportive care. Beyond the major pathogens, several other organisms cause neonatal meningitis with unique characteristics that require specific recognition and management approaches. Understanding these less common but significant pathogens helps complete the clinical picture of neonatal central nervous system infections. Listeria monocytogenes demonstrates unique pathogenic characteristics that distinguish it from typical neonatal meningitis organisms. Its ability to achieve transplacental transmission allows infection to establish before birth, creating congenital meningitis that presents immediately after delivery. The organism shows particular affinity for the brainstem, causing rhombencephalitis that affects vital functions including breathing and cardiovascular control. The formation of microabscesses throughout brain tissue represents Listeria's distinctive pathologic signature. Unlike the larger abscesses seen with some gram-negative organisms, Listeria creates multiple small foci of infection scattered throughout brain parenchyma. This pattern makes surgical drainage impossible while creating widespread tissue damage that can affect multiple neurologic functions simultaneously. Klebsiella pneumoniae presents modern therapeutic challenges through extended-spectrum beta-lactamase production that renders standard antibiotics ineffective. These resistance mechanisms force clinicians to use more toxic antibiotics like carbapenems while infection progresses, potentially worsening outcomes through delayed appropriate therapy. Enterobacter species possess inducible resistance mechanisms that can develop during treatment, creating the dangerous scenario where initially sensitive organisms become resistant while therapy continues. This pattern necessitates careful monitoring and often requires combination antibiotic approaches to prevent treatment failure. Coagulase-negative staphylococcus typically causes device-related meningitis in infants with ventricular shunts or other neurosurgical hardware. While generally less virulent than other pathogens, these infections often require device removal for cure, creating complex management decisions when neurosurgical hardware serves essential functions. Enterococcus rarely causes neonatal meningitis, but when infection occurs, outcomes typically prove poor due to the organism's intrinsic resistance to many antibiotics and tendency to cause persistent infection. The limited therapeutic options available for multi-drug-resistant enterococcal strains compound the management challenges. Candida species represent perhaps the most feared neonatal meningitis pathogen due to extremely high mortality rates that can exceed 70%. Fungal invasion of the central nervous system typically occurs in the most vulnerable preterm infants with multiple risk factors, and treatment options remain limited with significant toxicity concerns in neonatal populations. Initial meningitis therapy requires understanding why central nervous system infections demand fundamentally different antibiotic approaches compared to systemic sepsis. The blood-brain barrier that protects the brain during health becomes a therapeutic obstacle during infection, requiring specific drug selection and higher doses to achieve adequate cerebrospinal fluid concentrations. The empirical combination of ampicillin and cefotaxime reflects careful consideration of both pathogen coverage and pharmacokinetic properties essential for treating central nervous system infections. Ampicillin provides excellent coverage against Group B Streptococcus and Listeria monocytogenes while demonstrating reliable cerebrospinal fluid penetration when meningeal inflammation increases blood-brain barrier permeability. Cefotaxime serves as the gram-negative coverage backbone because third-generation cephalosporins achieve excellent central nervous system penetration and maintain bactericidal activity against E. coli and other enteric organisms. The dosing regimen of 50 milligrams per kilogram every 8 hours, increased to every 6 hours in the first week of life, accounts for immature renal clearance that requires more frequent dosing to maintain therapeutic concentrations. The higher ampicillin dose of 100 milligrams per kilogram represents a crucial increase from sepsis dosing because achieving bactericidal concentrations within cerebrospinal fluid requires overcoming the blood-brain barrier. Even with inflammation increasing permeability, antibiotic concentrations in cerebrospinal fluid typically remain only 10 to 20% of serum levels, necessitating higher systemic doses to ensure adequate brain tissue penetration. Understanding why gentamicin gets excluded from meningitis therapy illustrates important pharmacologic principles. Despite its excellent activity against gram-negative organisms in other body sites, gentamicin demonstrates poor cerebrospinal fluid penetration even during active inflammation. Additionally, the bacteriostatic concentrations achieved in cerebrospinal fluid prove inadequate for clearing bacteria from the central nervous system, where bactericidal activity becomes essential for cure. A cyclovir consideration acknowledges that herpes simplex virus can present identically to bacterial meningitis, particularly in neonates where maternal transmission creates significant risk. The devastating consequences of untreated HSV encephalitis justify empirical antiviral therapy when viral infection cannot be excluded clinically. Vancomycin addition becomes appropriate in specific scenarios where methicillin-resistant organisms pose increased risk. Late-onset meningitis in infants with neurosurgical devices creates particular concern for coagulase-negative staphylococcus or MRSA involvement, organisms that would not respond to standard empirical therapy. This initial approach prioritizes broad coverage and excellent central nervous system penetration while awaiting culture results that will guide more targeted therapy adjustments. Pathogen-specific treatment allows optimization of antimicrobial therapy. Once culture results identify the causative organism and susceptibility, testing guides rational drug selection. This targeted approach improves efficacy while reducing unnecessary broad-spectrum exposure that can promote resistance development. GBS meningitis treatment demonstrates how combination therapy can enhance bacterial killing through synergistic mechanisms. Penicillin G provides the primary bactericidal activity against this universally penicillin-sensitive organism, while gentamicin addition creates enhanced killing through different cellular targets. The combination achieves more rapid cerebrospinal fluid sterilization than either drug alone, potentially improving neurologic outcomes. The transition to penicillin monotherapy after clinical improvement reflects both safety considerations and antimicrobial stewardship principles. Once cerebrospinal fluid shows clearing and clinical status improves, continued gentamicin exposure creates unnecessary nephrotoxicity and ototoxicity risks without adding therapeutic benefit. The high penicillin dose of 450,000 to 500,000 units per kilogram daily ensures adequate cerebrospinal fluid concentrations for monotherapy effectiveness. E. coli and other gram-negative rod treatment requires careful consideration of resistance patterns that increasingly complicate therapy selection. Cefotaxime remains first line for susceptible organisms because of excellent central nervous system penetration and proven efficacy. Ceftazidime provides an alternative with similar pharmacologic properties but potentially different resistance profiles in some institutions. Meropenem consideration for extended-spectrum beta-lactamase producers reflects the reality that these resistance mechanisms render standard cephalosporins ineffective. The carbapenem class maintains activity against ESBL-producing organisms while achieving adequate cerebrospinal fluid penetration, though concerns about promoting further resistance make this a carefully considered decision. Listeria treatment requires ampicillin because this organism demonstrates intrinsic resistance to cephalosporins that would be ineffective despite excellent central nervous system penetration. The optional gentamicin addition provides synergistic activity similar to GBS treatment, though some experts prefer ampicillin monotherapy to avoid aminoglycoside toxicity. The principle of duration, based on cerebrospinal fluid sterilization, emphasizes that treatment length should be individualized rather than following rigid protocols. Achieving sterile cerebrospinal fluid serves as the objective endpoint that ensures adequate treatment before discontinuation, preventing relapse that could prove devastating. This pathogen-specific approach optimizes outcomes while minimizing unnecessary antibiotic exposure and toxicity risks in vulnerable neonatal populations. Treatment duration guidelines in neonatal meningitis reflect the balance between ensuring complete bacterial eradication and minimizing prolonged antibiotic exposure toxicity. Understanding these timeframes helps explain why central nervous system infections require much longer therapy than other neonatal bacterial infections. GBS meningitis treatment extends to 14 days minimum, calculated from the first sterile cerebrospinal fluid culture rather than from treatment initiation. This approach ensures that the countdown begins only after documented bacterial clearance, preventing premature discontinuation when organisms might still persist in protected central nervous system compartments. The timing reflects clinical studies showing that shorter courses result in unacceptably high relapse rates. Complicated GBS cases require extending treatment to 21 days when ventriculitis, abscess formation, or other complications develop. These scenarios create protected bacterial reservoirs that resist antibiotic penetration and require prolonged therapy to achieve complete sterilization. The definition of complicated includes persistent positive cultures beyond 48 hours, evidence of ventriculitis on imaging, or slow clinical improvement despite appropriate antibiotics. Gram-negative rod infections demand 21 days minimum because these organisms demonstrate enhanced virulence and tendency to establish persistent infection within brain tissue. Many cases require 4 to 6 weeks total therapy, particularly when E. coli or other highly virulent pathogens cause extensive tissue damage. The longer duration reflects both the difficulty of achieving bacterial clearance and the devastating consequences of treatment failure. Extended therapy becomes essential when abscess formation or ventriculitis complicates gram-negative meningitis. These complications create anatomic barriers to antibiotic penetration while serving as persistent bacterial reservoirs that can cause relapse if treatment stops prematurely. Some cases require surgical intervention combined with prolonged antimicrobial therapy lasting several months. Listeria meningitis typically requires 14 to 21 days, with duration depending on clinical response and cerebrospinal fluid clearance patterns. The organism's tendency to create microabscesses throughout brain tissue may necessitate longer therapy in some cases, though most infections respond within the standard timeframe. Cons meningitis, typically associated with neurosurgical devices, requires 10 to 14 days after achieving sterile cerebrospinal fluid. These infections often mandate device removal for cure, making hardware replacement timing a crucial consideration in treatment planning. The emphasis on documenting cerebrospinal fluid sterility through repeat lumbar puncture represents one of the most important principles in meningitis management. This objective endpoint ensures that bacterial clearance has occurred before discontinuing therapy, preventing relapses that can prove even more difficult to treat than initial infections. Monitoring during meningitis treatment requires systematic approaches to detect treatment failure, identify complications, and ensure optimal outcomes through careful observation and timely intervention. Understanding these monitoring strategies helps explain why neonatal meningitis demands such intensive surveillance throughout the treatment course. Repeat lumbar puncture indications reflect specific scenarios where treatment response needs objective assessment rather than relying solely on clinical improvement. Gram-negative rod meningitis mandates repeat cerebrospinal fluid analysis at 48 to 72 hours because these organisms frequently demonstrate delayed clearance or persistence despite appropriate antibiotics. The repeat procedure documents bacterial killing and guides decisions about treatment duration or alternative therapy. Lack of clinical improvement within the expected timeframe triggers repeat lumbar puncture to assess whether bacterial clearance is occurring despite absence of obvious clinical progress. Some infants show delayed clinical response, even with effective antibiotic therapy, while others harbor resistant organisms or complications that require treatment modifications. Persistent positive cultures after 48 hours of appropriate therapy suggests either antibiotic resistance, inadequate drug penetration, or complications like abscess formation that require additional interventions. This scenario demands immediate reassessment of antimicrobial selection and consideration of imaging studies to identify treatable complications. New neurologic findings during treatment can indicate progression of infection, development of complications like hydrocephalus, or treatment-related toxicity. These changes warrant immediate evaluation, including repeat cerebrospinal fluid analysis and neuroimaging to determine the underlying cause and guide appropriate interventions. Daily head circumference measurements provide essential monitoring for hydrocephalus development, a common complication that can occur despite effective antimicrobial therapy. Rapid head growth exceeding normal percentiles indicates cerebrospinal fluid accumulation that may require neurosurgical intervention through ventricular drainage or shunt placement. SIIDH surveillance involves monitoring serum sodium levels and urine output patterns because inappropriate antidiuretic hormone secretion frequently complicates central nervous system infections. This condition creates hyponatremia that can worsen cerebral edema and cause seizures, requiring fluid restriction and careful electrolyte management. Serial neurologic examinations assess treatment response and identify emerging complications through systematic evaluation of consciousness level, motor function, cranial nerve responses, and primitive reflexes. Changes in these parameters can indicate progression of infection, development of increased intracranial pressure, or emergence of focal brain damage requiring intervention. Imaging consideration becomes appropriate when complications are suspected based on clinical deterioration, persistent fever, or new neurologic findings. Cranial ultrasound can identify hydrocephalus and some abscesses, while MRI provides more detailed evaluation of brain tissue damage and complications requiring surgical management. Acute complications during neonatal meningitis treatment represent the immediate life-threatening consequences that can develop despite appropriate antimicrobial therapy. Understanding these complications helps explain why intensive monitoring becomes essential and why outcomes can remain poor even with optimal treatment. Seizures occur in 25 to 40% of neonatal meningitis cases, representing one of the most common and concerning acute complications. Think of seizures as electrical storms in the brain, where inflammation disrupts normal neural circuits, creating chaotic firing patterns that can become self-perpetuating. The developing neonatal brain shows particular vulnerability to seizure activity because immature inhibitory pathways cannot effectively control abnormal electrical discharges. The risk of status epilepticus, prolonged seizures lasting more than 30 minutes, creates medical emergencies requiring immediate intervention. Status epilepticus can cause additional brain damage through metabolic exhaustion and excitotoxicity, essentially adding injury on top of the existing infectious damage. Multiple antiepileptic drugs often become necessary because single agents frequently prove inadequate for controlling seizures in the inflamed brain environment. SIADH, or syndrome of inappropriate antidiuretic hormone secretion, develops when brain inflammation affects hypothalamic control of water balance. This creates a dangerous situation where the body retains excessive water while continuing normal sodium losses, leading to dilutional hyponatremia. The resulting low sodium levels can worsen cerebral edema and trigger additional seizures, creating a vicious cycle that compounds neurologic injury. Close sodium monitoring and fluid restriction become essential management strategies. Subdural effusions develop in approximately 30% of cases when inflammation causes fluid accumulation between the brain surface and skull. Most effusions remain sterile collections of inflammatory fluid rather than infected abscesses. However, when these collections create mass effect with brain shift or contribute to increased intracranial pressure, therapeutic drainage through subdural taps becomes necessary to prevent further neurologic deterioration. Ventriculitis represents extension of infection into the brain's ventricular system, creating a complication associated with very high mortality rates. When bacteria seed the cerebrospinal fluid pathways directly, treatment becomes extremely difficult because infected debris can obstruct normal fluid flow while creating protected reservoirs that resist antibiotic penetration. This complication often requires neurosurgical intervention combined with prolonged antimicrobial therapy. Late complications of neonatal meningitis develop weeks to months after the initial infection, representing the long-term consequences of inflammatory damage that occurred during the acute phase. Understanding these delayed manifestations helps families and healthcare teams prepare for ongoing challenges that may require years of management. Hydrocephalus affects 25 to 30% of meningitis survivors, developing when inflammatory debris or scarring disrupts normal cerebrospinal fluid circulation. Think of the brain's fluid system like a complex plumbing network where inflammation can create blockages or damage the drainage pathways. Communicating hydrocephalus occurs more frequently than obstructive forms because meningitis typically creates problems with fluid absorption rather than complete blockages at specific anatomical points. The decision to place a ventriculoperitoneal shunt represents a complex balance between relieving dangerous fluid accumulation and accepting the lifelong complications associated with artificial drainage systems. These devices require multiple revisions throughout childhood and create ongoing infection risks, but they remain essential for preventing progressive brain damage from uncontrolled hydrocephalus. Brain abscess formation presents particularly challenging scenarios, especially with certain pathogens like Citrobacter and E. coli that demonstrate enhanced ability to create localized tissue destruction. These organisms produce toxins and enzymes that directly damage brain tissue, creating cavities filled with infected material that resist antibiotic penetration. The result resembles having infected pockets scattered throughout brain tissue that serve as persistent bacterial reservoirs. Surgical drainage often becomes necessary because antibiotics cannot effectively penetrate the thick walls that surround established abscesses. The procedures require delicate neurosurgical techniques to remove infected material while preserving surrounding healthy brain tissue. Even with optimal surgical management, prolonged antibiotic therapy lasting weeks to months becomes necessary to prevent recurrence. Parencephalic cysts develop when areas of brain tissue die and are replaced by fluid-filled cavities. These cysts represent permanent scars from the inflammatory process, creating holes in brain architecture that cannot be repaired. The location and size of these cysts determine their functional impact, with larger cysts in critical brain regions causing more severe neurologic deficits. Multicystic encephalomalacia represents the most severe form of brain damage, where extensive tissue death creates multiple cystic areas throughout the brain. This pattern typically results from widespread vascular damage during the acute infection, leading to tissue infarction that heals with cyst formation. The resulting brain architecture bears little resemblance to normal patterns, explaining why affected children face profound developmental disabilities. Long-term outcomes following neonatal meningitis reveal the sobering reality that surviving the acute infection represents only the first challenge in a journey that often includes lifelong disabilities. Understanding these outcome patterns helps families prepare for potential needs while highlighting the importance of early recognition and optimal treatment. The overall adverse outcome rate of 40 to 50% means that nearly half of meningitis survivors will face some form of permanent disability. This statistic represents one of the highest morbidity rates among treatable neonatal conditions, emphasizing why prevention strategies and rapid treatment protocols receive such intense focus in neonatal intensive care. Pathogen-specific outcome patterns tell important stories about bacterial virulence and treatment responsiveness. GBS meningitis, despite being the most common cause, demonstrates the best outcomes with 25 to 30% sequelae rates. This relatively favorable prognosis reflects both the organism's lower tendency to cause tissue destruction and its consistent sensitivity to penicillin-based therapy that allows rapid bacterial clearance. E. coli outcomes prove significantly worse, with 50 to 60% of survivors experiencing permanent disabilities. This increased morbidity reflects the organism's enhanced virulence, tendency to cause ventriculitis and abscess formation, and the more complex treatment requirements that often delay optimal therapy. The gram-negative bacterial toxins create more extensive tissue damage than gram-positive organisms typically produce. Other gram-negative rods demonstrate the worst outcomes, with adverse sequelage rates reaching 80% in some series. These organisms, including Klebsiella and Enterobacter species, combine high virulence with increasing antibiotic resistance that can delay effective treatment. The result creates extensive brain damage during the prolonged time required to achieve bacterial clearance. Developmental delay affects approximately 30% of survivors, representing the most common long-term consequence. This encompasses a spectrum from mild learning disabilities to profound intellectual impairment, depending on the extent and location of brain damage. The developing neonatal brain shows particular vulnerability to inflammatory injury, explaining why cognitive impacts prove so common. Cerebral palsy develops in 15 to 20% of survivors when motor control areas suffer damage during the acute infection. The patterns vary from mild coordination problems to severe spasticity requiring lifelong supportive care. Early recognition and intervention through physical therapy can help optimize functional outcomes, though underlying brain damage typically remains permanent. Hearing loss occurs in 10 to 15% of cases through multiple mechanisms, including direct eighth cranial nerve damage, inner ear inflammation, or ototoxicity from antimicrobial therapy. This complication can range from mild high-frequency loss to profound deafness requiring cochlear implantation. Vision impairment affects 5 to 10% through optic nerve damage or cortical visual processing problems. Epilepsy develops in 10 to 20% as damaged brain tissue creates seizure foci that can activate months to years after the initial infection. Follow-up requirements after neonatal meningitis represent systematic approaches to detecting and managing the long-term complications that can emerge months to years after the initial infection. Understanding these surveillance strategies helps ensure that treatable complications receive prompt attention while providing families with realistic expectations about ongoing care needs. Hearing evaluation protocols reflect the high risk of auditory complications that can significantly impact developmental outcomes if unrecognized. The pre-discharge auditory brainstem response test provides baseline documentation of hearing function before discharge, establishing whether hearing loss existed at the time of acute illness resolution. This timing becomes crucial because distinguishing between infection-related damage and medication toxicity can guide future treatment decisions. The repeat evaluation at 3 to 6 months acknowledges that some hearing loss develops gradually as inflammatory damage progresses or as growing children reveal deficits that were not apparent during initial testing. Think of this like assessing earthquake damage to a building. Some structural problems become apparent only over time as the building settles and reveals hidden weaknesses. Early detection of hearing impairment allows prompt intervention with hearing aids or other assistive devices that can dramatically improve language development outcomes. Neurodevelopmental assessment schedules recognize that brain injury manifestations change as children grow and face increasing cognitive demands. Every 3 to 6 months during the first 2 years provides frequent enough monitoring to detect emerging problems while avoiding excessive testing that burdens families unnecessarily. This frequency reflects the rapid developmental changes occurring during this critical period when interventions prove most effective. Standardized testing at 18 to 24 months offers objective measurement of developmental progress using validated instruments that can guide educational planning and therapeutic interventions. This timing coincides with the period when reliable predictions about long-term cognitive outcomes become possible, helping families and healthcare teams make informed decisions about future care needs. Head imaging strategies balance the need to detect treatable complications against the risks and costs of repeated procedures. MRI at discharge provides detailed baseline documentation when initial imaging showed abnormalities, establishing the extent of acute damage and identifying complications like hydrocephalus that may require ongoing monitoring. The high-resolution images serve as crucial comparison studies for future evaluations. Repeat imaging becomes indicated when clinical signs suggest developing hydrocephalus, including rapid head growth, irritability, or developmental regression. Early detection of progressive ventricular enlargement allows timely neurosurgical intervention before irreversible brain damage occurs. Ophthalmology referral addresses the risk of vision complications that can significantly impact developmental outcomes if unrecognized. Visual impairments may not become apparent until children reach ages where formal vision testing becomes possible, making specialist evaluation essential for comprehensive assessment. This systematic follow-up approach ensures that meningitis survivors receive comprehensive care addressing the multiple potential complications while providing families with ongoing support during what can be a challenging recovery process.